So a very good evening to everyone. Welcome to the second webinar of the AIMS Pathology webinar series hosted by the Department of Pathology, All India Institute of Medical Sciences, New Delhi. Myself, Dr. Prasenjit Das, along with my colleagues, Dr. Rajni Jadhav and Dr. Madhu Rageshwari, will be moderating today's session. Now, I kindly invite Professor Chitra Sarkar, the chairperson of this webinar and our respected head of the department, to formally introduce today's esteemed speaker. Ma'am, please.
Good evening to friends in India and good morning to friends in the US. Dear faculty, colleagues, residents, friends, ladies and gentlemen. A very warm welcome to the second event of the AIMS Pathology webinar series entitled Under My Scope, which is being hosted by the Department of Pathology at the All India Institute of Medical Sciences, New Delhi. It's our proud privilege to have with us today one of our alumni, Professor Vikram Deshpande. A very warm welcome to Vikram to this webinar. It is indeed an honor for us that you have accepted our invitation at such short notice in spite of your busy schedule. Dr. Deshpande needs no introduction, possibly because he's given a number of webinars and we are all very familiar with him. He completed his MBBS from JIPMER Pondicherry and did his residency in pathology at AIMS New Delhi from 1991 to 1997. Subsequently, he left for the US and did his residency at the Mass General Hospital and Harvard Medical School, Boston from 1997 to 2001. He is currently professor of pathology at the Harvard Medical School and a pathologist at the Mass General Hospital. His clinical practice is focused on gastrointestinal diseases, but also includes bone and soft tissue pathology. His research interests are primarily centered on the study of pancreatic and hepatobiliary diseases. Dr. Deshpande has been an instrumental figure in establishing a novel disease entity, the IgG4 related disease. He is also the director of the MGH Tumor Repository, Tissue Microarray Facility, and the Biomarker Discovery Lab. He has published more than 250 original papers and reviews in a variety of journals, including the New England Journal of Medicine, Science, Cell, and Nature. He has also made contributions to a number of chapters in textbooks and serves on the editorial board of a number of prestigious journals, including the American Journal of Surgical Pathology. Incidentally, Dr. Vikram met his better half during his residency at AIMS, and Anita is also a pathologist. Vikram, please convey our best wishes to her. We have very fond memories of both of you in this department. For organization of this webinar, I must thank all my department faculty, colleagues, and residents, with special thanks to Professor Manoj Kumar Singh, Dr. Ruma Ray, and Dr. MC Sharma for their support. The department is proud of its team of gastrointestinal pathologists, namely Dr. Prasenjit Das, Dr. Rajni Jadhav, and Dr. Madhu Rageshwari, who will be moderating this webinar. I am very grateful to Dr. Venkat, who happens to be Vikram's batchmate during MD Pathology, and his dynamic young team led by Dr. Achal, Dr. Aruna, Dr. Kavneet, Dr. Ruchi, and Dr. Madhu, for all their efforts in getting this seminar, this webinar going. So once again, I welcome you all to this webinar, Getting Up Close and Personal with the Pancreaticobiliary Tract. Hope you all really enjoyed the slide seminar and the peek into the world of Dr. Vikram Deshpande. Thank you.
So with that, we can start the session. Over to you, Professor Deshpande.
Oh, thank you, Chitra, for that wonderful introduction. And thank you guys for the invitation and for all of the organizational work that you've done. I I must admit, for a second, I felt I was back in Ames, and this is now, it's been 25 years since I left, and for a moment, I felt as if I was back there in the corridors of Ames, and both me and my wife have such fond memories. As Chitra pointed out, I met my wife of now 28 years back there in Ames. Um, so let's start. What I thought I'd do is, as Chitra pointed out, I'm a gastrointestinal pathologist, but does a fair amount of dabbling in bone and soft tissue pathology. But what I thought today I'd do is I'd share with you 10 cases, and hopefully we'll be able to get through all 10 cases uh, from the pancreas, because for whatever reason, I've always considered the pancreas my first love. Much of my research started with the pancreas. I have dabbled in other areas, but the pancreas has been closest to my heart. Um, if you're on Twitter, do follow me. If you're on YouTube, I must admit, I've been on Twitter only for about a month or so, and it's been a phenomenal experience of people sharing cases. The PAT Twitter crowd is an extremely friendly crowd. So if you're on Twitter, do join me. If you're on YouTube, I do have some very nice videos on gastrointestinal pathology. So as Chitra pointed out, I met my wife, Anita, in 1991 at Ames, and I still remember that first week at Ames. This is me and her at a holiday. We, of course, we can't travel, unfortunately, because of COVID, but this is us in New Hampshire, which is about 100 miles north of Boston, a couple of months ago. Uh, as you can see, we look very relaxed. It was a lovely holiday up north. All right, with that introduction, um, you're going to get both a peek into my thinking, a peek into my world, and a bit of the pancreas for the ride. So let's start with case one. And as you probably know, most people, when they present
Sorry
cases.
to interrupt, Vikram. You need to share your screen.
Ah, sorry. Oh, you guys didn't see my screen at all. I'm so sorry. Looks good, Venki?
Yep, you're good to go.
Okay, so I'm sorry. That's the image I wanted you guys to see. That's my wife and me on a holiday a month or so ago. We've been married now 28 years. All right, case one. So these cases actually are, I have whole slide images that are hosted at Mass General, but shareable across the world. And if you don't have the link, ask any one of the organizers today. They can send you a link, or perhaps I'll post it on Twitter as well. So the link to this case is, there's two sets of cases. There's Pancreas 1 and Pancreas 2. This particular case is Pancreas 2, case 10. All right. So take a look at this image and spend a few seconds looking at this image. Do you think this is benign, or do you think this is malignant? Right? So look, and in all fairness, if I can grab my pen, that looks pretty benign, doesn't it? It looks extremely bland. All right, so here's a higher power image. Don't say I'm not generous. Same image, higher power. It looks bland, doesn't it? Extremely bland. My question for you is benign or malignant? And you probably are aware that I'm probably going to trick you, right? I'm not going to give you an obvious answer right at the front of this talk. This is malignant. Those two glands I showed you, both of those are malignant. And why do I know it's malignant? It's because those glands were from this lymph node. And you might ask me, how do I know it's a lymph node? I know it's a lymph node because there's a subcapsular sinus right here. Now, that's the way I define a lymph node. If I do not see a subcapsular sinus, to me, it's not a lymph node. The only time when I'll make an exception to that rule is, with colon cancers, you need 12 lymph nodes. If I'm short of that one lymph node, I might surrender that rule. But in general, no subcapsular sinus, no lymph node. So back to this story, this is metastatic adenocarcinoma because it's a lymph node. All right, so let's flip and look at the pancreas itself. So now remember, we are in the middle of the pancreas. Look at that epithelium. Is that benign or is that malignant? All right, now we're going to flip into a lower power image. Is that benign or is that malignant? It's malignant because look at the distribution of the glands, right? There is no lobular architecture whatsoever. In fact, I'm going to flip and show you, I'm going to share with you the whole slide image. Let's see. So this is case 2, pancreas 2, case 10, which is right here. So this is the case I've been showing you. That's the positive lymph node, right? And there's the subcapsular sinus that I went on and on about. And you'll notice I'm going to flip, my face is going to flip to the left when I do these whole slide images. And that's because I have 2 monitors, just in case you're wondering why I'm flipping to my left. Now I look good this way, but I also look good this way. I'm only kidding. So when you look at the pancreas proper, you'll notice that one is, of course, this is a very well-differentiated adenocarcinoma. The other thing is that this is not some form of chronic pancreatitis, and it is not chronic pancreatitis because it's non-lobular. It's this random distribution of the glands that makes it cancer. And you'll also notice that it's infiltrating very focally into the pancreatic fat, which to me is another helpful sign of a very well-differentiated adenocarcinoma. Question for you. Would you call that perineural invasion? I personally would not call that perineural invasion. I have very strict criteria to call something perineural invasion, and I require those glands to be plastered to a significant proportion of the nerve before I call something perineural invasion. What I would call these is glands that are flirting with the nerve, but not quite at it, right? So this is not what I would call perineural invasion. So it's that random distribution that I find very helpful. Of course, that works when you have a resection specimen. When you have a biopsy, that's not going to work, right? For a biopsy, you're going to have to use somewhat different criteria. All right, so let's go back to our PowerPoint presentation and I'll swap this. All right, so that random distribution to me is very, very helpful. The other thing that I personally find very helpful in making a diagnosis of a very well-differentiated adenocarcinoma is these very angulated glands. So benign glands tend to be round. Any angulation to me is very concerning for cancer. And this applies not only to the pancreas, this applies to anywhere in the GI tract. Benign glands are seldom angulated. And of course, when you look at this on your own computers, one often used to say, go and look at your slide under your own microscope. Now, of course, that I suspect in the next 5 years or so, that statement is going to change, and it's going to say, go and look at it on your own computer. Uh, so if you go back to your computers using that link, you'll see that there are areas that show significantly more atypia, but by and large, the case that I put out is very well differentiated pancreatic adenocarcinoma. So this was indeed invasive ductal adenocarcinoma, well differentiated, metastatic to a lymph node. That basically is one of the fundamental problems in pancreatic pathology. How do you distinguish between a very well differentiated adenocarcinoma and chronic pancreatitis? And I'm typically a very simple guy. I carry at the back of my head very simple rules. And the rule that I follow is based on location, location, and location. It's like buying a house, right? You need to have the right location. All right, so I'm going to ask you a few questions, and I so wish I had you in the audience. I could point to one of you guys and ask you what you think, but unfortunately, this is what we are with a pandemic. All right, so question for you guys: do you guys think this is benign, or do you think it's malignant? And you know I'm playing tricks on you, right? This is obviously malignant. And the reason why it's malignant is not because it looks obviously malignant, but it's smack in the middle of the nerve. This is what I would call perineural invasion. One more case. Looks banal, right? I mean, I wouldn't go around town calling that malignant right off the bat, but it is malignant. And it's malignant because it is in the middle of a nerve. It's smack in that nerve. So to me, perineural location is virtually diagnostic. Now that's an easy one, right? That's an easy rule to follow. I think most of us learn it very early in our residencies. But this is a rule that I think is often forgotten, although talked about in the literature. There's actually a paper that talks about this. And this is the rule, right? Any gland, regardless of the degree of atypia, that is adjacent to an arterial channel is extremely concerning for cancer, right? Regardless of the degree of atypia. And we consider in the pancreas, now I wear two hats. I wear the liver hat and the pancreas hat. When I'm carrying the pancreas hat, which is what I'm wearing right now, we think we are very special in the pancreas. And the reason why we are special is because our ducts in the pancreas do not run in parallel to the arteries. That's what happens in the liver. The liver guys have the duct and the artery running together. Our ducts do not run parallel to the artery. Therefore, if you have a duct next to an artery, that's very suspicious for cancer, right? So location number 2 that is very concerning for cancer is duct next to an artery. All right, so let's put that in practice. Take a look at this. So a duct, it's got a little mucin on it, right? A little bit of mucin here. Let me grab my pen. So there's a little bit of mucin here. Columnar cells that are somewhat polarized. Is this pannin or pancreatic intraepithelial neoplasia? How about this? This is another duct from another case. Now this looks, I grant it, it looks a little more revved up, but roughly it looks the same, right? It has that stellate configuration, a little bit of mucin on the top. I'll give it to you that this looks a little more revved up. Is this pannin? Well, one of these is pannin. Believe it or not, the other one is an invasive adenocarcinoma. So which of this is pannin and which of this is invasive adenocarcinoma? It turns out that this is pannin and this is invasive adenocarcinoma. And I know that because that gland I stole from right here which is right next to an arterial channel. In fact, this is what has been referred to as the Pannon-like variant. So Pannon is a preneoplastic pancreatic lesion, but you have a pancreatic cancer that mimics Pannon. This is the Pannon-like variant of pancreatic adenocarcinoma. And I knew this was cancer not because of the architecture, not because of the cytology, but solely because of the location. It's smack adjacent to this arterial channel, and that makes it cancer in my eyes. So location, don't forget that, location next to an artery. All right, just one more feature, one more location. Now take a look at this. This looks atypical, doesn't it? There's pleomorphism. Look at the cytology. I'm a trained cytopathologist. I spent an entire year at AIMS talking about cytopathology. This looks very, very atypical, doesn't it? In fact, for God's sake, it looks worse than the adenocarcinoma that I showed you just a minute ago. Now, here's the kicker. That duct, I showed you that image from right there in that blue box, right? That duct is in the middle of a lobule. And in general, in pancreatic pathology, virtually anything in a lobular configuration, with exceptions, and you'll notice this in pathology all the time. You have rules and you'll have exceptions, but you've got to live by the rules, because if you live by the exceptions, you'll never be able to sign out anything. The rule in pancreas is if it is in the lobule, it is generally good unless you have overwhelming evidence to prove that it is bad. And if it is between the lobules, it's a suspicious character. Take a very close look at any ducts between the lobules. So I'm not going to spend too much time talking about the cytologic features. The classic features are pleomorphism, nuclear membrane irregularities. Wenke can tell you a lot more about this than I ever can. But the one feature that I think is somewhat neglected is that most pancreatic adenocarcinomas, I'm talking about well-differentiated adenocarcinomas, have this very pale cytoplasm. This is, in fact, the foamy variant of pancreatic adenocarcinoma. So watch for that pale cytoplasm and think cancer when you see that abundant pale, and in this case, frothy cytoplasm. Most benign and reactive ducts tend to have that eosinophilic cytoplasm. All right, so all through this, I'm going to give you a few lessons that I've learned. I'm going to call this wisdom from the Deshpande. And I figured I have gray hair, right? So I qualify for a person to give wisdom. You don't have to listen to my wisdom, but I think personally I qualify to hand out wisdom. The other thing is I have crossed 50. I did that a couple of years ago. I won't tell you exactly how long it's been since I've crossed 50. And so I believe that I have the ability to hand out wisdom, and I'm going to be handing out wisdom throughout this talk. Right. So as far as this case is concerned, this is the wisdom I have to give you, right? So pancreatic adenocarcinomas are bland, yet they metastasize and yet they kill. So they can look bland, but yet be malignant. That's typically our worst nightmare in pathology. And since there are people that might be listening to this talk who I know fairly well and they know me from childhood, I'm going to have to be very careful with my language. And so all I can say is that they scared the bleep out of me, right? So this is one tumor that I'm really afraid of missing. And with that, we're taking questions, are we?
Yeah, Professor Deshpande, that was a very good description of a very common problem, because we often stumble to differentiate chronic, basically pancreatitis and well-differentiated adenocarcinoma. There are not much questions from the attendees, but I have two quick questions. If you can address those. You mentioned it is one of the very helpful feature if you see gland which is situated next to a duct, artery. And often we use a sign to identify lymphovascular emboli in colorectal carcinoma that we call as orphan arteriole sign. So is it the same thing? Are these glands are also sitting that indicates it is a lymphovascular emboli next to a artery? The question number one is that. And secondly, if in such scenario, when we stumble to differentiate these two conditions, what we discussed, is SMAT4 immunohistochemical stain will be helpful. Loss of the nuclear stain may be helpful. If you can comment on that.
Oh, thank you. Those are wonderful questions. Thank you, Prasenjit, for those questions. So yes, the often artery sign is helpful. And what Prasenjit is talking about is when you see an arterial channel and you see a circumscribed aggregate of tumor cells right next to it. Now, the rule, and that rule works primarily because arteries and veins tend to run together, right? So if you see an artery and you see tumor but not the vein, that's the often artery sign. That's very concerning. Prasenjit, I would go beyond that. So I'm a great believer in the elastic stain. And I personally think we underestimate vascular invasion. And this applies not only to the pancreas, this applies to the entire GI tract.
Yeah.
So early in my practice, I used to do a single elastic stain. Now I do multiple elastic stains. There's a caveat to that rule, though. And you've got to remember that just because you find more of something doesn't necessarily mean that it is predictive of outcome. So what we've never shown is in the colon, people have shown that if you get a single elastic stain, you improve prognostication. We've never proven in the pancreas that we're improving prognostication, and less so if you do multiple elastic stains, I'm uncertain as to whether I am doing more good or more harm. Nevertheless, we're trying it out, but it is very clear to me that we tend to underestimate venous invasion. Try it out, guys. Try an elastic stain. It's widely available. It's not very expensive. I promise you, you will double your rate of picking up venous invasion. And of course, as you know, perhaps because of the very high mortality of pancreatic adenocarcinoma, it may not make such a huge impact in the pancreas, but in the colon, it makes a huge impact. If you have extramural venous invasion in the colon, our oncologists may offer chemotherapy even when the patient has an N0 status. So it is hugely important in the colon. And Prasenjit, I'm sorry, I've forgotten your second question.
My second question was about utility of SMAT4 immunohistochemical stain to differentiate.
SMAT4. It's a good stain, right? So
Yeah.
loss of SMAT4 would be virtually diagnostic of an invasive adenocarcinoma. There's occasional IPmns that lose SMAT4, but we'll come to that later. The problem with SMAT4, right? So in theory, it's a great stain. In practice, it turns out to be not so great. One is it's a very hard stain to do. The antibody is not great. I've seen SMAT4s from all across this country, and no one produces a great stain. It tends to be very pale. The other problem is only 50% of pancreatic adenocarcinomas lose SMAT4. So if you find loss, it's great. If you don't find it, it doesn't help you one way or the other.
Yeah.
And the third thing, and I think this is often forgotten, that the pancreas is not the only tumor that shows loss of SMAT4 expression. So colon cancer may show loss of SMAT4 expression as well. So if you're going to use it to pinpoint a primary of unknown origin, watch for that. It is true that pancreas is perhaps the highest percentage of pancreatic cancers show loss of SMAT4, but there's certainly other tumor types that show loss of SMAT4.
Yeah.
Difficult state to work with.
Thank you so much, sir. You can proceed to the next case, please.
All right. Case 2. And like I told you guys, some of this history may be true. Some of this I may have made up, and I of course do it to protect our patients. So this is a 67-year-old female with a family history of pancreatic cancer, and an MRI detects a pancreatic mass. Now you can imagine how concerned this woman was. She has a family history of pancreatic cancer. She's a physician, so she knows what's going on. She knows her risks, and she gets an MRI every couple of years, and one of those MRIs detects a pancreatic mass and gets an EUS guided FNA biopsy. I'm not going to show you the smears, but they were very bloody and very hard to interpret. But this is what our US guided FNAs often look like. They tend to be rather bloody, but we do get intact microcores. And if you look at this core, there's a significant amount of fibrosis. This is obviously acinar tissue. Fibrosis, and I can promise you I'm not playing any tricks on you guys. This is what it is. There was no tumor here. All it showed was fibrosis, right? So what do you do next? Obviously, she had a discussion with her endoscopist, she had a discussion with her surgeon, and they decided that they think that pancreatic malignancy is very high up on the differential. We've got to get another biopsy. And so we get biopsy number 2. Same result, fibrosis, no malignancy. Again, there was this discussion, those slides go around town. Boston has several very large hospitals. We are, of course, the largest, but then there's Brigham, there's the BI, there's a dozen other hospitals. There's a hospital about 9 miles north of here that my wife works at. So it does the rounds. Lots of pathologists look at it. We all agree we can't really make a diagnosis of cancer. The biopsy findings are non-specific. So they decide to resect this. Now you might say, why resect this? We don't have a biopsy proven adenocarcinoma. The problem in pancreatic pathology, as you'll discover, is that while FNA, the sensitivity for malignancy of an FNA is pretty high in some places, I think in our place it's around the 90% range, it is still not 100%. So if the clinical suspicion of pancreatic cancer exists, our pancreatic surgeons, like many surgeons across the world, will go in and take out the pancreas even though they do not have a biopsy-proven adenocarcinoma. So, resect it, and I see the pancreas. How are we doing for time? Okay, so there's whole slide images that I'm not going to share with you, but you can do that on your own time. But here's what the pancreas look like, right? So if you look at this is intact pancreatic parenchyma. And if you look here, there's a fair amount of loss or atrophy of the pancreas. Not surprising, right? If the ducts are clogged, the pancreas gets atrophy. The inflammation, interestingly enough, was centered on the pancreatic duct. Look at that, right? And if you don't believe me, there's another duct. There's very little inflammation outside the duct. Here's another duct. In fact, this duct, it's one of my favorite shapes. It has acquired this sort of stellate shaped. But notice how ductocentric this inflammation is. And that's a key feature of this entity. And I hunted because I thought this was type 2 autoimmune pancreatitis. And I can tell you off the bat, there was no malignancy anywhere. To make a diagnosis of type 2 autoimmune pancreatitis, I need to find neutrophils. And I hunted and I hunted. And perhaps if you squint really hard, there's a couple in here. But that was it. This was not neutrophil rich. And that's sort of very disappointing. Just to back up for a minute, if you look at the rest of the pancreas, there's no storiform fibrosis and there's no obliterative phlebitis. Those are features of type 1 autoimmune pancreatitis. I'm thinking type 2 autoimmune pancreatitis, right? Totally different animals. They have the same name, but never put them in the same basket. They have nothing to do with one another. All right, so I'm thinking type 2 autoimmune pancreatitis, and I get a PD-L1 stain. And you're probably asking yourself, has this man gone crazy? PD-L1, that's a cancer stain. What is he doing with it with autoimmune pancreatitis? Hold your horses, I'll tell you why. Before we go there, clearly the ductal epithelium shows nice membranous staining for PD-L1, right? It comes from this paper that we wrote last year that was headed up by my former fellow of mine, Rajiv Gupta, if he's listening. Hi, Rajiv. And what we essentially showed that PD-L1 in the ductal epithelium has a reasonable specificity and sensitivity for autoimmune type 2 pancreatitis. Now, is this 100% specific? No way. So don't come back and write to me tomorrow, oh, I have a pancreatic adenocarcinoma with positive for PD-L1. Yes, they are, but the incidence is relatively low. So in the right context, this is a fairly decent stain for autoimmune pancreatitis type 2. And I'll tell you how it helps, right? So here's another, this was a 45-year-old man with history of pancreatic mass and pancreatitis. Again, this image is online. The whole slide scanned image is online. This is what we typically see with EUS-guided microcore biopsies, fragments of tissue. But now if you look at it, there are actually neutrophils in there, and you don't have to squint all that hard. Now, this is what Giuseppe Zamboni, this is now going back, a good friend of mine from Italy, going back to 2004, described as granulocytic epithelial lesions. Although, when he described it, he described the neutrophils in the ducts, but I've gone on ahead, and Giuseppe, I call these granulocytic epithelial lesions as well. Because remember, on core biopsies, you tend not to see ducts, but you will see lobules. So neutrophils and lobules, to me, speak, in the right clinical context, speak type 2 autoimmune pancreatitis. But then, think of this. Think of yourself sitting in your chair at your microscope, looking down at these ducts, and you all of a sudden remember this Deshpande guy talking about these very well differentiated adenocarcinomas and these lessons and this wisdom he's been giving you. And that is when that PD-L1 stain comes in really handy. So for example, this is a granulocytic epithelial lesion if those neutrophils are connected with those ducts. But the problem with EUS-guided biopsies, as you'll notice, is that it is like minced meat, right? So the ducts and the neutrophils, and you get a admixture of all sorts of things. You don't often you don't get a good sense of the architecture, and that is where the PD-L1 stain comes in really handy. And you'll see nice membranous staining here. I'm sorry, it's a little fuzzy, but believe me, take my word for it. No tricks. This is nice membranous staining for PD-L1. And when I see that, I tend to get a better night's sleep, right? I feel so much better about my diagnosis of type 2 autoimmune pancreatitis. All right, so we talked a little bit about this. I'm going to go very quickly on this. There are two variants. Type 2, this is the case we talked about, is not an IgG4 related disease. Type 2 autoimmune pancreatitis is characterized by the presence of these granulocytic epithelial lesions. It is very different from type 1 autoimmune pancreatitis. And one of the most important things I can tell you today is that if you do not make the distinction, you will receive a call from your endoscopist or your clinician to make the distinction, because clinically, they are completely different animals. So for example, this type 1 autoimmune pancreatitis, after you make a diagnosis in the pancreas, these patients will have relapses both in the pancreas and outside the pancreas. So you'll have a mass in the lung, a mass in the brain, a mass in the kidney. While type 2 autoimmune pancreatitis is a pancreatocentric disease, you do not see it outside the pancreas. Time for words of wisdom, guys. So my words of wisdom for this case, don't forget I got gray hair, so I can give you words of wisdom. And the word of wisdom in this case is, every time I make a diagnosis of type 2 autoimmune pancreatitis, I tend to sleep poorly. I get up with nightmares. And the nightmare scenario is that someone calls me and tells me, ask me the question, do you remember that case of autoimmune pancreatitis? That's all, that's a call where your heart sort of tends to sink, right? Because you know something has gone wrong. Your clinician is never going to call you and pat you on the back. They're probably going to call you only when you probably made an error. And I'm being facetious, but the reality is that you can see neutrophils and inflamed pancreatic parenchyma around the pancreatic adenocarcinoma, the peritumoral rind around the pancreas, right? And that's the nightmare scenario where the needle samples that, but not the cancer. So the one piece of advice I can leave you with is make sure, talk to your clinician and make sure that they offer them steroids and that the lesion shrinks at the end of 4 to 6 weeks after steroids. If the lesion has not shrunk, you probably have an underdiagnosed pancreatic adenocarcinoma in there. And with those words of wisdom, we'll take questions.
Good evening, sir. I have two
Hey,
quick
Rajni.
questions for you. The first question is that, in the cancers, do we need to use any specific clone of PD-L1 antibody and a specific IHC platform for the chronic pancreatitis cases? And the second question is that, do you see these cases in children? Because yes, we have seen a case, so that was reported by Dr. Prasenjit, and that we discussed in our clinical combined round. So that is rare. So we saw one case in a child, and I think that child responded beautifully to steroids, and the mass went down because the clinicians were suspecting a malignancy.
Thank you, Rajni. So yeah, so the first question is the clone of PD-L1. I for we use the regular PD-L1 that we use for our cancer diagnostics, and it's the it's, oh God, it slipped my mind. I'll send you I'll send you uh, I'll send you a link to the antibody that we use clinically. Perhaps it's probably simpler if you guys just go to Google, PubMed and use my last name and autoimmune pancreatitis. Take a look at the paper. I think we have the antibody in there. But essentially, it's the same antibody that we use for cancer diagnostics, which is really convenient, right? The reason why we did this study was, one is, of course, it's a huge challenge. I portrayed it as a relatively easy diagnosis. To make the reality is it's a huge challenge, because you do not want to be mistaking underdiagnosing pancreatic adenocarcinoma for sure. And the other reason is that PD-L1 antibody is widely available now across the world because of its implications in cancer therapeutics. The other thing is in children, absolutely. I've seen cases in children. I remember I reviewed the first paper that was published, I think it was in Clinical Gastroenterology and Hepatology many, many years ago. I've certainly seen it in children. That said, I think in general, when you talk about autoimmune pancreatitis or you talk about IgG4 related disease, I'm very skeptical about making a diagnosis in children. I'm very careful. Before I make a diagnosis of either of those entities in children, I want to be 120% sure that that is what I'm dealing with. Because in general, IgG4 related disease is a disease of the elderly. Type 2 autoimmune pancreatitis is a disease of patients in their 40s, 50s, and 60s, so slightly younger, but definitely you see them in children. It does exist, and it's just statistically speaking, it turns out to be not so uncommon in children. And that's primarily because there are not very many other pancreatic diseases that you see in children to begin with. So certainly something to keep in mind. One final point, I don't believe you can make a diagnosis on a fine needle aspirate, not on smears. I'm one of those who believes that you need microcores or a core biopsy to make a diagnosis of type 2 autoimmune pancreatitis.
Yeah, sir, we do get a lot of fine needle aspirates and EUS get guided biopsies, but they are actually very difficult. So the tissue is really small to make a diagnosis. And this case, which I was talking about, yes, so it is rare, and the patient responded beautifully. So that's why it is, I think, under publication also. So that was a nice case, and IgG4 stain was also put, so that was negative. And the child
Wonderful.
responded beautifully. So that is the nice thing about the case.
Right, and that's really the proof of the pudding, right? I mean, you can't really use that entirely to make a diagnosis, but it is very reassuring when you see a swift response to steroids. All right, shall we go on?
Thank you. I think, sir, you can go to the next case. So we'll be taking the rest of the questions at the end of the session regarding this case.
All right, so one final word about that case. Yes, indeed, that I did eventually call that type 2 autoimmune pancreatitis. Unfortunate, right? I mean, this is the thing you want to spare our patients of. We do not want to resect these patients, particularly given the fact that this is such a steroid responsive disease. All right, so this is case 3. All I told you was that this is a cystic lesion in the pancreas. This is 6 centimeters. I am going to not go to whole slide images to save a little bit of time. So this, remember, this was a 6 centimeter lesion, and because of that, no EUS guided FNA was performed. Any lesion greater than 3 centimeters goes straight for pancreatic resection, or at least in a relatively young patient will typically go straight for a pancreatic resection because the risk of malignancy is high. And it was indeed resected. And if you take a look at this, there are actually, on the whole slide images platform, there's actually 3 slides that I have scanned. And check out those images, guys, because they're really good. There's no lag, and they scroll in and out very, very quickly. So here's a cyst, here's a cyst, here's a cyst, here's a cyst. So it's one of these cystic lesions in the pancreas. And one of the slides has this really pretty image. One of our residents, I forget whether it was a resident or a PA who did this. They took a beautiful section. This is the duodenum, right? This is the main pancreatic duct. Here's the bile duct down here. And you can see that the lesion involves the main pancreatic duct all the way to the ampulla. Isn't that phenomenal? And then it's intraductal, it's papillary, clearly papillary. Often this is, might as well the cat's out of the bag. In any case, this is an intraductal papillary mucinous neoplasm. You could often the cores tend to be somewhat myxoid, and you're probably asking yourselves, it's an IPmn, yeah, but where's the mucin? And this one had a few goblet cells. I must admit, there's not a lot of mucin in this on this particular slide, but clearly slightly eosinophilic columnar cells. But there were other areas that were overtly gastric. So here's another area. You can see papillarity here. And here you see this papillary framework. And here, this is clearly foveolar type epithelium, right? This is the stuff that you see in the stomach, right? So because it looks like epithelium from the stomach, we refer to this as a gastric type intraductal papillary mucinous neoplasm. But there's more. There's always more when you sign out with me. There's always some excitement. And here's the excitement with regards to that case. There's some sneaky characters around here, and we'll take a better look at them. They shouldn't be here. Remember, the rest of this pancreas is completely atrophic. This is typically what happens with IPmn. Those ducts are clogged, the rest of the pancreas disappears. So we really shouldn't be seeing these random ducts. These scare the crap out of me. Pardon my French. This is, again, we are looking at the lining epithelium. Now, this is micropapillary architecture, little tufts of high-grade atypia. This is high-grade dysplasia. And when you see high-grade dysplasia, look. And what are you looking for? You're looking for invasive cancer. And I'm already worried. So the moment I saw this sort of angulated profile, I was concerned. I knew there was something bad going on. Remember, most ducts are round in shape. Now here we go. This is starting to get rather worrying, isn't it? Look at that. These cells, they shouldn't be there. They're getting angulated now. And now I could argue that this is desmoplastic stroma. You know, one of the problems with desmoplastic stroma is what looks desmoplastic to you may just look fibrotic to another person. So I think, you know, it's helpful, but there is some level of inter-observer disagreement with regards to what we call desmoplastic stroma. But to me, this angulated profile is very worrying. And of course, we now know that some pancreatic adenocarcinomas can be very, very well differentiated. And indeed, this is an invasive carcinoma arising from an intraductal papillary mucinous neoplasm with high-grade dysplasia. This was a gastric type IPmn, and this involved both the branch duct and the main duct. And I like to get all of those elements that I just said into my report. So this is one of those IPmns with limited invasion. There's one study, perhaps the largest study out there, which defined these IPmns with limited invasions to tumors less than 20 millimeters in size. That's an area which is an open question right now. How do you measure these tumors, right? Often, as you'll see as you scroll through these slides, you'll often see microinvasive or small invasive carcinomas. I shouldn't use the word microinvasive. I think that's an unfortunate term. You'll see tiny foci of invasive carcinoma arising from multiple cysts. But what is interesting, and it's hard to make too much about this because it's hard to get a sense of how big these tumors actually were. But it is very amazing to me that even though these tumors are showing very limited invasion, 41% of patients were dead at 5 years. So limited invasion can kill in the pancreas. So think of that, which essentially means that you must detect early invasion in an IPmn. And that's where my words of wisdom will come in. And the word of wisdom I have, and I think this is not what I have, this is what I think most people agree with, is that unfortunately, this is what you have to do as a GI person. You have to submit the entire cyst, and there are people, believe me, who put the whole pancreas through. My record is 250 sections. I haven't yet gone beyond that. But if it comes to 250 section, you've got to put in 250 sections because the outcome is defined and dictated by the invasive carcinoma. So it behooves you to detect even small foci of invasion. So IPmn with small invasive carcinoma. And that's
Yeah.
case 3.
So that was a very nice case, sir. So it was basically an IPmn with invasive carcinoma. So as there is no question from the attendees, I will ask one small question. There is another entity which is called IPmn with concomitant invasive adenocarcinoma, where we don't see direct link or direct connection between the invasive carcinoma and the IPmn foci. So what is your experience regarding that?
That's an awesome question. Right. So what Prasanjit was referring to is what I showed you was invasive carcinoma, obviously arising out of the IPmn, but not infrequently, you'll see an IPmn on one slide and disconnected from that IPmn, you'll see a focus of invasive carcinoma, and there may be a distance of even a few centimeters between those two foci. And I can tell you, it is not uncommon to find tiny IPmns in someone, a pancreas resected for pancreatic adenocarcinoma, completely incidental, tiny IPmns sitting somewhere in the pancreas, unrelated to the pancreatic adenocarcinoma. Biologically, that's somewhat of a different phenomenon. And what I think is that you've got to remember that, to me, IPmn is a field defect. And therefore, when you see an IPmn, it really puts the entire pancreas at risk for cancer. And the important thing, the message to take from that is that unlike an MCN, you resect an MCN, the patient is cured. You resect an IPmn, the patient is never cured because the rest of that pancreas is at risk for pancreatic adenocarcinoma. So we've seen a number of cases over the years in cases in which the surgeon has done a Whipple for an IPmn, and then they come back with pancreatic adenocarcinoma in the remnant or the tail of the pancreas. So I think clinically, the message is that resecting an IPmn is not a cure, and that these patients do need to be followed up for extended periods of time because I think they are at increased risk of pancreatic adenocarcinoma.
Yeah. Thank you. I will ask another important question, what was raised by one of the attendees, how to measure the T size when there are multiple small foci of invasion from an IPmn?
Do I get paid extra for answering that question? Because the reason I say that is there are no rules, unfortunately. It's really hard. I can tell you what I do. I just add them up and, so for example, in the case I showed you, what are you going to do, right? There's a millimeter, there's a fraction of a millimeter on one cyst, and there's a fraction of a millimeter on the other cyst. I add them up for the T stage.
Okay.
Whether that's a good idea or not, I don't know. There are people who have actually measured the depth of invasion. In fact, in this case, because the invasion is so limited, you could measure the depth of invasion. Of course, then the controversy is, where do you measure it from? Which basement membrane? And I've sat down together at conferences with some of my colleagues, trying to debate this issue. I think at a very practical level, I mean, I do what a lot of us do, just common sense, just try and add it up. And then again, it's an eyeball approach, right? So you roughly, I don't know whether you guys carry, but I don't have a micrometer. I have a very simple microscope sitting back here. I eyeball it and just add it up in my head. But I think regardless of the T stage, I think the important thing to remember is put that whole pancreas through. It's a pain. I know it's a pain, but it makes a huge difference to the patient. And two, once you have invasion, the chances that cat is going to slip out of that bag is high. You've got to follow them up, because you've got to treat them and follow them up as you would follow any patient with a resected pancreatic adenocarcinoma.
Thank you so much for your words of wisdom. So you can go to case number 4.
I'm being somewhat facetious about my words of wisdom. They aren't really. Well, some of them may be words of wisdom, but some of it, I'm just having a little laugh at myself. As people who know me, at least in the last 10 years or so, I tend to laugh at myself quite a bit. I enjoy laughing at myself. If you can't laugh at yourself, you're a boring person, according to me. All right, so case 4. I don't know whether you guys have this problem. Did I give you any history? No, I didn't. So take it from me. Most of our pancreatic cysts are detected incidentally, right? So patient comes in with vague abdominal pain and gets a cross-sectional imaging, and they identify a cyst, and unfortunately, there is only trouble once. So for example, frankly, I do not want cross-sectional imaging because I'm dreadfully afraid that somebody will find a pancreatic cyst in me and then stick an endoscope in me, and all the wonderful things that happen once that happens. Anyway, one of the problems I have with cross-sectional imaging is I'm often left wondering, where is the lesion again? I think this is where the lesion is. I hope so. And because it was small enough, they stuck a needle in it and got an EUS guided FNA, drew some fluid. Most of the cells were very poorly preserved. There's a single cluster of cells. Now, maybe some of those are histiocytes. I'm sure the cytopathologists will argue with me about that. Some of them could be lesional cells, and this is the problem I have with FNA cytology of pancreatic cysts. I think it's a very challenging area, and we can talk about that in another time. Anyway, so you're probably asking yourselves, what about the CEA? Of course, we measure cyst fluid CEA in most cases. It was 157. Our cutoff is 200, so not quite there. Close but no cigar, as Ben Pilch would say. If it is above 200, that's a mucinous cystic neoplasm, but it's sort of bordering on that level. The amylase, frankly, I think is useless, so I wouldn't even bother. This is how it was signed out, the pancreatic cyst cytology, fair enough. I think the primary message here is that we did not see malignant cells, right? That's the important message to convey. Everything else is, icing on the cake. But we do another thing at the Mass General. We use next-gen sequencing to sequence our pancreatic cysts. And that's what the cytopathologist was alluding to. And this is what we found, right? So we found an added 1A mutation and a GNAS mutation. So you're probably looking at me right now and saying, what does that mean? And until a couple of years ago, we were looking at one another and asking the same question, what does it mean? I think the best paper out there is this paper in terms of what these mutations mean in cyst fluid. And that is way too complicated for me, right? as the older I get, the less I can remember. So this is above and beyond what I can make sense of. This I can make sense of. So I made this table for myself. I have this on my, right in my office. All right, so one, added 1A doesn't even, not even figure in this table. So I don't know what to do with added 1A. So I say, forget it. GNAS mutation. All right, so GNAS, you find it in PDAC, IPmn carcinoma, IPmn high grade, IPmn low grade. Now, what I can say that the cyst is not, is it's not an MCN and it's not a serous cystadenoma. Is that helpful? Somewhat, but not a lot, right? So it goes back to, what do you do with these cysts? We still don't know what the cyst is. It has a GNAS mutation, but that doesn't mean a whole lot. The criteria for management for pancreatic cyst changes often. This is a relatively old slide, but it still works. I mean, if you have a big cyst, if you have a mural nodule, or if you have atypical epithelial cells, you buy yourself a pancreatic resection. And this was large enough to be resected and therefore was resected. And this is a case that I had a couple of years ago. It looks a little like Swiss cheese, although I wouldn't buy this Swiss cheese. There's just not enough cheese here. It's all cystic. Look at this higher power, look at the cyst. Here's the cyst, fibrous walls. I can't really see much of this magnification. Now I see a lining epithelium. This is not an IPmn, right? Where's the mucin? Where's the papillarity? And this is not an MCN either. Where's the ovarian type stroma? Absolutely no mucin whatsoever. The only mucin I found, if I look really hard, maybe that looks a little blue. That was the only mucin on the entire cyst. So I'm sitting here at my desk, and I think it was a Friday evening. What am I, and the surgeon is calling me, the patient's calling him. What do I call this? Carlos Fernandez is our chief pancreatic surgeon. I want a diagnosis. Tell me what this is, right? So I told him, I cannot call it an IPmn because there's no mucin and there are no papillary areas. I can't call it a mucinous cystic neoplasm either. And then there's this entity, I don't know how many of you ever used it. I've never used it, called a simple mucinous cyst. It's supposed to be an IPmn without features of an IPmn, sort of, you know what I'm saying. But again, there was no mucin. So what did I call this? I call this a retention cyst. Now, ideally, you shouldn't be calling things retention cysts unless you can find a pancreatic stricture or something like that, because ultimately a pancreatic cyst is the ducts get strictured and then there's back-end dilatation of the ductal system. All right, so I call it a retention cyst. So what about the GNAS mutation? What am I supposed to do with that? Well, it turns out if you look carefully at that paper, 5 of the 7 retention cysts had one of these mutations. Now, I agree there's no GNAS mutation in here. And a couple of pseudocysts also had mutations. And so the message I want to give you guys, and I don't have all the answers to this, but the message is that you can have mutations without a neoplastic lesion. So for example, you take the skin of an elderly Caucasian, you'll find P53 mutations. So my argument is, do not equate mutations with a neoplasm. Mutations occur even in histologically normal mucosa. So I stuck with my diagnosis of retention cyst. As you can imagine, the surgeon wasn't particularly thrilled with that diagnosis. What? Look at his reaction. I took this, I did all of this work. I sat in the OR for 8 hours and I took out a retention cyst. So be it. That's what the histology showed. So lessons that perhaps I didn't touch upon this all that much, but I think pancreatic cytology, as Venki will tell you, is really hard because you will overdiagnose, particularly with cyst cytology. You will overdiagnose, you will underdiagnose, and I think you need to develop a really thick skin. It's a tough act, but it's one of the best tools we have for predicting malignancy in an IPmn. And molecular assays, interestingly enough, can tell you between a mucinous and a non-mucinous cyst, but don't really help you, or very rarely help you, in making the distinction between a benign cyst and a malignant cyst. And what the surgeon really wants to know is if this is malignant or close to malignancy. and that'll give them a sense of what to take out and what not to take out. That's it. Questions?
Thank you, sir, for such a nice case. And as you told, it is very right. It is really difficult on cytology, and Dr. Venkat has actually taught us a lot on the pancreatic cytology. So we do correlate all the FNAs with the radiology or the imaging of the case, and we do call the clinician also back in many cases, as it is really tough because we get less material, and normal and abnormal cells, they are mixed in the FNAC or the EUS guided biopsy. So it is really tough. And even so, our clinicians, they try to do the next generation sequencing, though it is so in the pipeline. So, but yes, they are getting it done in some cases. But because the normal tissue mixes up, so it is hard to actually confirm the diagnosis on that also. So in our cases, we do try to correlate with the imaging. I would like to actually ask you that, is this ARID1 a mutation, which all pancreatic lesions can show this mutation? So like nowadays, it is being studied in neuroendocrine tumors also. And as you told, it can be seen in the pancreatic tumor. So which all pancreatic lesions can show ARID1A mutation? Because nowadays IHC is also available. So can we do put up ARID1 IHC on the cytology or the histology?
Excellent question. And unfortunately, I will not have a specific answer for you. You know, one of the things I was telling, I think I was talking to my mom yesterday, and I told her one of the advantages of crossing 50 and carrying gray hairs is that you can, it's very easy to say, I don't know. You know, in my younger days, I used to feel very apologetic about saying, I don't know. I can look at you in the face and say, I don't know. Actually, I don't know the answer to that. You know, I think they are detected in some IPmns, but the incidence is not very high. It is very uncommon. So I wouldn't go about, you know, looking for ARID1A mutations using immunohistochemistry. So in terms, because the incidence is so low, then it's not a very diagnostically helpful thing. We don't use ARID1A in the context of in IHC. You know, so for example, you see ARID1A mutations in Barrett's esophagus, and potentially it could be one of those markers that could be used to predict those who progress, who don't progress. Unfortunately, again, the incidence is so low that it's just not, it's never going to be a diagnostic marker out there. The precise incidence of ARID1A mutations in mucinous cysts, I'm sure somebody's Googling it up right now. I cannot remember off the top of my head. But I think the other message I wanted to get across to you guys is, do not equate mutations with a neoplasm just because you have a mutation, right? So often you'll see this, you know, we do next-gen sequencing all over the place, and we'll do next-gen sequencing on these biliary brushings, and I'll have a surgeon calling me and saying, I see mutation A, mutation B, mutation C is this cancer, and I can. They want to do a hepatectomy based on a mutational spectrum, and I tell them you cannot do that. And the example I always use is, you take skin of a Caucasian man or a woman, 70 years old, you will find P53 mutations in there, completely normal skin, right? And I always think of the pancreas, particularly because most of us carry pannin mutation. I always think of the pancreas as a soup full of mutations. So careful with the next-gen sequencing. It may not be the answer that you're looking for.
So another quick question from the audience. So somebody asked, could you possibly teach more on the rationale behind the diagnosis of retention cyst? If you could just tell 2-3 points on the diagnosis of the retention cyst.
That's an awesome question. So retention cyst, in theory, is a cyst that develops because there's obstruction of a pancreatic duct. So think of it, duct obstructed, fluid accumulates in what is behind the duct, in the ductal system, and the cysts expand. Now, we see these cysts, if you take up any pancreas, say a pancreas resected for pancreatic adenocarcinoma, you'll see these little cysts in the pancreas unrelated to the cancer. And again, those are because it is assumed or theorized that the duct gets clogged, the fluid has nowhere to go. I mean, obviously the pancreas produces a fair amount of fluid, and that fluid accumulates in the ductal system, right? So in theory, before you make a diagnosis of a retention cyst, you should have some level of obstruction of the ductal system, particularly a cyst that was that large. The problem, the challenge with this particular case is that I did not have any evidence of an obstruction anywhere. So in theory, you could certainly challenge my diagnosis, but my question back to you then would be, what do I call this? I can't call this Pannon, I can't call this a simple mucinous cyst, I can't call this an IPmn. And so by default, I threw it in this category of retention cyst. But I agree. I mean, I think the challenge is that, you know, mechanistically speaking, I am on very flimsy ground, if that makes sense.
Thank you, sir. You can proceed to the next case.
All right, this one, this is Pancreas 1, case 3. I am going to show you one of these images because I think this is a really cool case. I've seen 3 of them. And as you'll see, I'm not very good at diagnosing this entity. So very well circumscribed lesion, guys, right? Fibrotic stroma all around. That's of course the pancreas. And I'm going to zoom very quickly into high power because they're little nests of cells. Because what I want to show you is this. There's something unique about this neoplasm. I will fully confess to you guys, the first time I see this, I think neuroendocrine. And if you're thinking neuroendocrine, then you're sitting in my head and thinking exactly like me. Because every time I look at this, I say, this is neuroendocrine, chromogranin, synaptophysin, negative. And that's when you start thinking, right? After that first round of immunohistochemistry, that's when you really start thinking. There's something very unique about this case. Take a look at this. This looks like, these look like a little like fried eggs, don't they? Very monotonous nuclei, clear to pale eosinophilic cytoplasm, but I want you to pay very close attention to these distinct cytoplasmic membranes. And there's another thing that perhaps hasn't caught your eye, but should, the vascularity. Look at these vessels, right? So that's the tumor we're going after. Whole slide. Swap. There we go. All right, so that's the image I want you to burn into your brain. The clear cytoplasm, distinct cytoplasmic membranes, the extreme vascularity. In fact, if you do a CD34 or a vascular stain on this, and I'm not saying you should, it'll blow your mind, the amount of vessels in there. In fact, well, maybe it doesn't look exactly like it, but I'm going to convince you that that image I showed you looks like this. And this is a classic serous cystadenoma. Now, let me show you why they look similar. Very monotonous nuclei, pale cytoplasm, slightly eosinophilic, distinct. Let me see if I can get this pen working. Distinct cytoplasmic membrane. Where's my pen? And sorry, I'm trying to hunt my pen down. There we go. No, I'm going to do the laser pointer. That's better. What I want to point out to you is the vascularity. Here's a vessel, and the vessels are hugging that epithelium. It's as if they let go, they're going to fall down and die. It's that close a hug. And of course, the reason why they're clear is because they have glycogen. Can you believe we used to use, these are the stains we used to use to make a diagnosis of Ewing sarcoma. It amazes me how far we have come. Anyway, long story short, if you guessed it right, you're a genius because this is a solid variant of a serous cystadenoma. Can I tell you something? If you make this diagnosis in a day, you're probably overdiagnosing it. I demand that you take at least a week to make this diagnosis because this is rare enough and challenging enough. And the reason I want you to take a week before you make this diagnosis is because you've got to think of other entities. The other entities you must think of is renal cell carcinoma. And you may say, why renal cell carcinoma? Clear cells, distinct cytoplasmic membranes, vascularity. And remember, patients don't come telling you, don't come with a little cheat sheet telling you that I have renal cell carcinoma. In fact, often what happens is that these are late metastases. The surgeon doesn't know that the patient has had renal cell carcinoma. The patient has forgotten that they had renal cell carcinoma, although if you lift their shirt, you'll certainly see evidence of a renal cell carcinoma. So late metastasis, remember that. Clear cell pancreatic adenocarcinoma, probably not, right? Because these are very infiltrative lesions. Solid serous cystadenoma, very well circumscribed. Clear cell neuroendocrine neoplasm, Ranjan will be horrified at this example of my example of clear cell neuroendocrine neoplasm, because this isn't all that clear. But anyway, this is the entity I think of when I see one of these. Fortunately, these are uniformly positive for chromo and synapto. Solid serous cystadenomas are negative. And so that's your differential diagnosis. I will throw in a pecoma because they can look pretty clear too, and you can see them in the pancreas. Sorry about that noise. There's a chopper that's landing on top of this building. So these are very rare tumors, right? What you will see more commonly is these variants of serous cystadenoma, the macrocystic, the microcystic, and the unilocular. Unilocular, again, quite uncommon, but extremely troublesome diagnostically speaking. But regardless, whether it's solid or non-solid, the individual cells, this is one instance where the cytology becomes very helpful. The architecture may or may not help. The individual cells have that unique appearance, and that is how you should arrive at a diagnosis. All right. Oh, I need to give you some words of wisdom. Oh, my word of wisdom is that I demand that you take at least a week before you make a diagnosis of a solid variant of a serous cystadenoma. Anything less than that is unacceptable as far as I'm concerned. I'm only kidding.
Thank you, sir, very much for that perplexing case. To be honest, we have never seen a solid variant of cystadenoma, serous cystadenoma. And I can see many of our attendees have already mentioned all this differential diagnosis. So as there is no question, we can proceed to the next case to save some time. Thank you.
All right, so I'll go very quickly through this. Thin walled cyst on the anterior surface of the pancreas. And it's really nice that somebody's actually put two arrows. I promise I did not put these arrows. I think one of my radiology colleagues helped me with this. So this was actually sitting on the anterior wall of the pancreas. And when we looked at this grossly, it had these thin walled cysts. And when we punctured them, there was clear fluid. I was up in the frozen section lab, in fact, when this specimen came in. And once it was deflated, there was nothing to see. It was one of those this dramatic grosses that became nothing the moment we punctured the cyst. And here's what the cyst looked like when it's collapsed. It looks what I refer to as a little like minced meat. It just looks not very pretty. Single layered lining epithelium. It almost looks papillary, doesn't it? I promise you it's not papillary. It's just because the cyst has collapsed on itself is giving it this sort of weirdly sort of frondy papillary appearance. And if you look at the lining epithelium, it's not very, hang on just one second. It's very nondescript, sort of columnar epithelium. And what was interesting is I always have a tale to tell at these things. I think this case is at least now at this point 15 years old, and I was a very junior attending. I didn't really know what I was doing. It's really hard in your first few years when you're signing out, because you really, however much training you've had, until you start signing out, you never really know what you're up against. I got EM done, and the EM guy told me there is neuroendocrine differentiation. And I said, you got to be crazy. You're probably seeing the normal adjacent pancreas. And after I said that, I put the slide back on my microscope, and I'll tell you a hint. This is what I do, right? I often let my slides sit in my desk, and I don't know what it is. I let it sit on my desk for a week. It's funny, at the end of a week, I have these inspirational ideas that often come in. And after that call with the EM guy, I started taking a closer look at it, and then I started seeing bits of acinar differentiation. If you take a really close look, you'll see these zymogen granules here. And not only these zymogen granules, these cells carrying these zymogen granules actually take a little dip, like little ectopic crypts, right? there you go. There you go again. It's obviously Acinar differentiation. Um, and it was positive for trypsin. That was the only stain we had in those days. Today we use BCL10. So a cyst lined by a single layer of cuboidal cells with evidence of acinar differentiation, and that is, you must have all guessed the answer by now. In those days when I made this diagnosis, this used to be referred to as an acinar cell cystadenoma. Today, the official terminology is acinar cystic transformation of pancreas. I'll admit I'm not a fan of that term, but whatever. Um, it's a disease of typically of younger individuals. It's common in women, and it's completely and totally benign. Now, in terms of differential diagnosis, the wisdom I can leave you with is that the acinar differentiation in these cysts can be very, very subtle. And if you do not see it, in fact, it's here. I don't know whether you see it. It's right there, right? You see that acinar differentiation? And you've got to hope and pray. If you go down on your knees and pray, you'll see acinar cell differentiation. Of course, we have IHC. In fact, we have much better IHC today than we had 15 years ago. If you do not see that acinar cell differentiation, you should consider those two entities, serous cystadenoma and a retention cyst. So by words of wisdom, I'm sure lots of people will be unhappy about this this particular word of wisdom. I mean, I do feel apologetic about delayed reports, but I think it's more important for you to get the right answer than a quick answer, right? This is a statement from one of my colleagues who was called about a delayed case, and he told the surgeon, "Do you want a quick answer or the right answer?" And the answer is always the right answer, isn't it? But I mean, I'm being facetious, but the reality is, I think some cases, you just need to work through some of these cases, and it takes time, and it takes a couple of rounds of immunohistochemistry, and it takes you share these cases with people, and often, now you have things like Twitter and things like that, and, reach out for help, and perhaps the best, I forget who said this to me the other day, but, your best immunohistochemistry is your colleague. Go show it to a colleague, and often an idea that doesn't occur to you occurs to them. And that's it. Questions? Come on,
That
guys.
that
Where
was
are
a
you?
very nice case, sir. I've never reported this entity till now, at least in my career. But as we are going slow, so audience are asking to present more cases. So we'll be taking most of the questions at the end. So we'll be actually collecting the questions, and then we'll be taking all of them at the end. So you can proceed to the next case.
All right, sounds good. All right. How much time do we have? We have.
You can go on a little longer, Vikram. I think the people who want to hear you will continue. So you can take your time and
Okay.
cover up your pieces.
I have license to continue, guys, from the boss. Oh, this is a fascinating case, and this sort of goes to show um, what happens as classifications evolve, right? And there's a couple of other lessons that I learned with this case. So a cyst in the distal pancreatic duct, and this is one of the most, I'm a sucker for gross images. This is one of the most gorgeous examples of a growth, right? So you can see this is the main pancreatic duct. This was the resection margin, and you see this papillary proliferation in the main pancreatic duct, and this is the heart of the lesion, right? This is a massively dilated pancreatic duct, and there's this stuff sitting in and creating a mass. Um, Very low power view. Here's the main pancreatic duct. Believe me, this is the main pancreatic duct filled with this papillary proliferation. That papillary proliferation is now extending into the secondary ducts. The background pancreas is completely atrophic. It has this broad papillary processes, right? So this is the pancreatic duct, broad papillary processes. You look down at the cytology, and where's the mucin? No mucin. Therefore, less likely to be an IPmn, right? Uh, in general, when you see common things are common, ladies and gentlemen. So when you see an intraductal pancreatic tumor, you must think of an IPmn first. But the question I would ask you is, where is the mucin? It's papillary, all right, but where's the mucin? And I'll point out to you, take a good look at these nuclei. Look at those nucleoli. Oh, they look like little darlings, big cherry red nucleoli, that granular eosinophilic cytoplasm. Of course, I had no idea what this was, right? So then I'm leafing through the prior reports, and whoops, 2004, he's had a Whipple. What? And here's the growth, not as pretty as the one I showed you, but nevertheless, this is the main pancreatic duct. There's the lesion. Again, it's all intraductal, very high power. It's the same thing. No mucin, big prominent nucleoli, that sort of amphiphilic cytoplasm. It's the same thing. Whatever happened in 2004 is now happening in 2012. As I said, the first thing you should think of is an IPmn. An IPmn comes in 3 flavors: gastric, intestinal, and pancreaticobiliary. This didn't really look like any one of them. I'll make another admission to you guys. I have never made a diagnosis of a pancreaticobiliary IPmn, even though we are a high volume pancreatic resection center. I'm not sure who calls that, but I certainly don't. What about an IOPN? Oh, this is a gorgeous example, gross example of an IOPN. There's the main pancreatic duct. Here's all the stuff sticking in the cyst. Here's what an IOPN looks like on low power, that granular, abundant eosinophilic cytoplasm. This is our case. Could this be an IOPN? Here's the IOPN. Could this be an IOPN? Maybe, but the cytoplasm isn't quite right. But let's keep that. I wouldn't dismiss the thought. Let's keep it at the back of our mind. There's another intraductal tumor that you must think of, and that's an ITPN. That's what an ITPN looks like. Could this be an ITPN? This, what I'm showing you on this image, is an ITPN, but could our case be an ITPN? The cytoplasm isn't quite right, but maybe. So that's our differential diagnosis. We have an intraductal proliferation that's papillary. That's our differential diagnosis, right? So long story short, I can go on until the end of today talking to you about all of the various things I thought about, but I did a keratin 19 stain. Now, all 3 entities I talked about a minute ago should be keratin 19 positive. Bang, keratin 19 negative. Aha, guess the stain, trypsin, right? So this is an acinar cell carcinoma, but it's intraductal. We went back to the 2003 case. This is the fascinating thing about pathology, and one of the most concerning things about pathology, right? You can always go back in time and prove yourself or somebody else wrong. Often it's proving yourself wrong. And although I confess, in 2003, I was in India, so I couldn't have signed out this case. Anyway, back in 2003, trypsin was positive. The keratin 19 was negative, although the keratin 19 very nicely highlights the cells of the pancreatic duct, right? So that's very pretty. So it's intraductal, no mucin, there's acinar cell differentiation, and just about that time, this paper came out from Olka Bastuk on the intraductal variant of acinar cell carcinoma. Perfect match, but there's a twist, all right? So hang on, don't go away, hold your horses. We had a very fine PA, so our pathology assistants are awesome. He found this little nodule at the very tip of the pancreas and submitted a section, and this is what the section showed. Monotonous proliferation of cells. To me, when I see this, first thing I think of is neuroendocrine, and the next thing I think of is acinar cell carcinoma. But here's a hint, right? This works really well, believe me. If you see easily found mitotic figures, you're probably, like here, you're probably dealing with an acinar cell carcinoma. And elsewhere, it had this classic acinar cell differentiation, right? So these lumens, these rounded lumens, and these cells polarized all around it. This is acinar cell carcinoma. And if you don't believe me, here's the trypsin stain, strongly positive, the chymotrypsin that is negative. So the twist in this case is, yes, it's an intraductal acinar cell carcinoma, but it also had an invasive component. What is interesting is that this variant of acinar cell carcinoma behaves a lot better than the conventional variant of acinar cell carcinoma. And this patient has done well and it continues to survive even today. And that would be most unusual for a conventional acinar cell carcinoma. So this variant, the intraductal variant of acinar cell carcinoma, I think, has a better behavior than conventional acinar cell carcinoma. So when you see an intraductal proliferation, think first IPmn, and if it isn't an IPmn, think of these other entities. And the lesson I've learned, and this is sort of broadly applies to pathology, and this is what happened with, remember we called our 2003 excision an IPmn. So don't force it into a category that it doesn't fit into. And believe me, if it's a semi-good fit, and I say this somewhat facetiously, there'll be somebody who's going to describe an entity with a better fit.
Thank you, sir, for that very interesting and eye-opening case. To save some time, I will request you to just proceed to the next case. Thank you.
All right, case 8. This is fascinating. All right, so typically one does not wash one's dirty linen in public, but I've crossed 50, right? So I can offer words of wisdom, but I can also show you my mistakes. Now, I'd encourage you to take a look at the whole slide images on this case. So the story is this man with a prior history of pancreatic adenocarcinoma with, think of this, with metastasis to the liver, and now with a colonic mass. And 9 times out of 10, that's going to be a met to the colon. We see these all the time now, mets, to the colon, to the stomach, to the small bowel. And I'm looking down my microscope. And what is worse about this case is not only was it, well, it wasn't officially my case, but I was co-signing or helping one of my junior colleagues out, right? And so if I get this wrong, it's doubly bad. Not only have I failed myself, I've failed my junior colleague who probably thinks I know nothing now. You look at this, the mucosa is completely intact, right? Most of the tumor is submucosal, and you look at the histology, this looks serrated, for God's sake. Now, there is a variant of colon cancer that's serrated, but that's not very common. This is weird. This does not look like a colon cancer, right, guys? I hope you'll agree with me. All right, so I wasn't sure. The question was, is this a MET? Is this a primary colon cancer? It was going to make a difference to the patient, and therefore I did immunohistochemistry. I gave it what we call out here $1 million workup. CDX2, it's positive, but not as positive as most colon cancers are. So for example, some nuclei are very weakly positive. Remember, pancreatic adenocarcinomas can be positive as well. So that's not specific. Look at the keratin 7, strongly positive. Keratin 20, pathetically positive. This is one situation where the 720 actually helps, right? With colon. Colon is classically 20 positive, 7 negative. And now this is not obeying the rules. So it's now time to bring out the big guns. One of the big guns is SATP2, a marker of colon cancer. And guess what? Negative. Whoops. All right, somebody asked the question about SMAD4. This is the problem with SMAD4. Is this intact or is this lost? I would interpret this as intact. I promise you this wouldn't have helped one way or the other. If it was lost, it is more likely to be pancreas. All right, so are we confused? The histology suggests maybe a MET. The immunohistochemistry is a bit all over the place. The 720 was a complete bust. So were we, totally confused. So what do? You start comparing it with the originals, right? So here's the liver met. It does not look like the colon, right? Does it look like the colon? No way. So the colon looks different from the liver met. Here's the pancreas. Does that look like the colon? No way. But there's a caveat. You've got to remember this patient was treated with neoadjuvant therapy, right? And therefore, the histology is not the same as the original. So our hands were somewhat tied, right? So we are limited in what we can do in terms of comparison. But at the very least, I can say that the colon did not look like the liver and probably did not look like the pancreas. So what diagnosis did I make? Metastatic pancreatic carcinoma to the colon. Was I right? Well, I don't know. You'll find out in a second. But I mean, my evidence was that this was submucosal, right? So this mucosal should mean primary, submucosal should mean met. IHC was conflicting. And my, use common sense is what I often say. PDAC, pancreatic adenocarcinoma, is an aggressive beast. And this particular beast is known to show aggressive behavior. It had met to the liver. All right, so our clinicians were not happy with my diagnosis, obviously. I did not do this. Our clinicians did this. So we sequenced the tumor, what we refer to as a snapshot assay, which we have about 150 genes or so are sequenced, and then we look for about 60 or 70 fusions. So we did all three. We did the colon, we did the pancreas, and we did the liver. So the colon had a P53 and KRAS mutation. That's okay. You could see that in the colon. We did this, and we identified a fusion. This is R-spondin, an R-spondin 3 fusion. We identified the same mutations, as you'll see, the same codons in the liver with the same fusion. Now the all-important question, pancreas. What about the pancreas? If the pancreas showed an identical snapshot mutational profile and an identical fusion, then I'm good, then it's met. Fortunately, this is what it showed. I'll give you a second to look at this. No fusion. And although there was the mutations in P53 and KRAS, the wrong codons, right? So essentially, this pancreas never went anywhere. This patient has a pancreatic primary with no residual tumor and now has a new colon primary to met to the liver, right? So I got it wrong and molecular assays proved me wrong. So this is a primary colonic adenocarcinoma with met to the liver, and the pancreas has nothing to do with this. So lessons that I've learned, and this is a perfectly good example. I did everything right, and yet I got the answer wrong. And this is happening more and more often. In the old days, we would get away with this, right? Shouldn't use the word get away, but what I'm trying to say is that was the limit of our ability. And molecular assays now, not infrequently, particularly in the metastatic setting, prove us wrong. But as you saw with the retention cyst, it can also lead us astray. So you've got to be very careful about how you use molecular diagnostic. It's helpful in areas, but it can also lead you astray in other areas. And that's it. Are we moving on?
Yes, please, sir.
Okay. Just in the interest of time, I'm going to skip 9 and perhaps I'll go just very straight to 10 just to finish up the story. This is case 10, and it's an elderly man with obstructive jaundice. And I'm going to ask you, what do you think is the differential diagnosis when you see an elderly man with painless obstructive jaundice? Here's my differential diagnosis, right? Wait for it. Pancreatic adenocarcinoma, number 2 pancreatic adenocarcinoma, number 3 pancreatic adenocarcinoma. You get the message, right? So the most important thing to think of, the most important entity to think of in an elderly man with painless obstructive jaundice is pancreatic adenocarcinoma. So after you've done that about 100 times, you should think of other entities, and this is one such entity. So very low power, higher power. If you take a look at this, I promise you there's no malignancy in here. There is no well-differentiated adenocarcinoma. I'm not trying to trick you guys. If you look here, I'm trying to get the pen to work. There we go. Let's see if I can go backwards. So there's fibrosis, there's inflammation, and this is what I would call storiform type fibrosis, right? And if you look on higher power, you see plasma cells, you'll see fibroblasts, you'll see lymphocytes. And there is something here that you don't often see on a biopsy, and this is, a takeoff from the naked artery sign, or the isolated arterial sign. There's an arterial channel, and here's a circumscribed aggregate of inflammatory cells right next to that arterial channel, and that is very concerning for obliterative phlebitis. This is one stain when I'm thinking of IgG4 related disease and autoimmune pancreatitis. This is one stain I always get, an elastic stain. And here you go, it's very nicely highlighted, the focus of obliterative phlebitis on the elastic stain. The problem with this case, and there's always a problem, isn't it, is that the IgG4 stain was pathetic, right? I would typically, with type 1 autoimmune pancreatitis, this is what I was thinking of. Type 1 autoimmune pancreatitis, it's a diffuse proliferation of IgG4 positive cells. This was the only area where I saw a few cells, and I barely made it to 10. Let's not even talk about the IgG stain because it has so much background staining. So the problem, to make a diagnosis of type 1 autoimmune pancreatitis, histologically speaking, I need the characteristic features, and I do have them, right? So I have a dense lymphoplasmacytic infiltrate. I showed you storiform fibrosis. I showed you obliterative phlebitis. So that's check, check, check. But I do also need to show greater than 10 plasma cells. And when you have to struggle to get to 10, I think then that's a problem. And I've seen occasional cases where I never make it to 10. The one thing I want you to remember is that this is not a diagnosis, particularly when you're dealing with a needle biopsy. This is not a diagnosis you should make in a clinical vacuum. So what did I do? I reached out to my clinician and asked him, were there multifocal other lesions? And he said no. I asked the imaging guy, I went to the radiologist and asked him, do you think this is type 1? And he said, maybe. I'm not absolutely sure. And therefore I got a biopsy, right? So he was being facetious, but he asked me, why are you asking me when you have a biopsy with you? Of course, we were joking. He understands exactly what I'm talking about. And that's the kind of relationship you'll have to develop with your clinical colleagues if you're going to make this diagnosis. Serum IgG4, unfortunately, was not elevated. And that happens in about 20% of cases. If all else fails, your clinician will try a diagnostic response to steroids and look for that very swift response. But ultimately, I think between the histology and the imaging, I felt fairly comfortable about making a diagnosis of type 1 autoimmune pancreatitis, and this is what I called it. So the last lesson, I promise you, no more lessons, I learned is trust your H&E, because immunohistochemistry can lead you astray. The H&E is more often right than the H&E is more often right than the immunohistochemical stain. And finally, look to your wild side. Think of your younger days. This case did not actually meet all of the rules for a diagnosis of type 1 autoimmune pancreatitis. But occasionally, you just need to break those rules, look to your wild side, and you should be able to make a diagnosis, even though an individual case does not follow the rules. I can tell you that I kept a close watch on this patient and made sure that there was that lesion responded swiftly to steroids. And I promise you it did. And hence I'm showing you the case. If it turned out to be pancreatic cancer, I probably would have not shared this case with you. And that's all I got, guys. Remember that the slides are on the web. I'll send you the link on Twitter. Sign up to Twitter. Believe me, it's a lot of fun. With that, I'll stop, and perhaps I'll stop sharing, and perhaps we can take a few questions if there are.
Thank you, sir, very much. So that was a very nice case. I want to ask one question regarding IgG4 IHC or the cases which are suspected IgG4 related disease on biopsy. So if we don't get the serum levels from the clinician and the imaging findings, so do we actually make a provisional diagnosis of IgG4 related disease or not?
Yeah, that's a very interesting question. We are, of course, very spoiled because Because we've become a referral center, I have access to all of the information, virtually all of the information when the patient comes here. And I think the other advantages we have is that we become like a referral center for IgG4 related, for the study of IgG4 related disease. So we have clinicians who are very adept at making this diagnosis. I think problems arise when two things. One is pathologists haven't seen enough of the disease. And you've got to remember that there's all sorts of mimics of the disease that now are getting written about all the time. The other problem is clinicians who are not very adept at making the diagnosis as well. And I think it depends really on the context in which you're signing out. So I'm very happy to say consistent with IgG4 related disease, because I know that this report is going to my rheumatologist who knows exactly what to do with my report. I think if you're practicing outside the context, I think you should, particularly if you have a clinician who's not seen very many of these cases, even if you have a serum IgG4, I would say use descriptive terms. Don't make a flat-footed diagnosis of IgG4 related disease. Put in all sorts of caveats in there. Make sure you measure IgG4, make sure you have a response to steroids, things I never have to do. But outside that context, in a large general hospital where you don't know who, this is one of the problems as a pathologist, right? You don't know who's actually reading that report eventually, because the patient could go to one physician and then switch and go to another physician, and you've no idea how much that other physician knows of all of the nuances with regards to a diagnosis of IgG4 related disease. And so what I would say is be descriptive, be very careful, because I suspect you'll see more mimics of the disease. This is what happened over the last 10 years or so. I've ended up seeing more mimics of the disease than the real thing. And so, throw in those caveats. Caveat number one, IgG4 positive cells can be seen in a variety of other diseases. There are a number of mimics of the diseases. Malignancy can mimic IgG4 related disease. And the less you know of the clinician, I would say more the caveats to throw out there.
So one more question regarding the case number 8. So that double primary, so pancreatic primary, which was treated with the therapy, and a new colonic primary. So most of the audience, they're asking questions regarding that case, as nowadays we also do get many cases in which there are two primary cancers or multiple cancers. So is the molecular analysis or the molecular testing recommended for clinching a diagnosis in those kind of cases?
Oh, that's an excellent question. So it depends on how much access you have to these molecular assays, right? So we do next-gen sequencing. You'll be surprised, it's a wealthy country, but yet we have our own challenges. And one of our challenges is that insurance companies don't necessarily pay for our services, and which becomes a huge cost on our divisions. This particular case, I'll admit, I said it looks like colon. It's doing everything. It's doing everything like a MET does. The immunohistochemistry does not help us one way or the other. I just go with a MET to the colon. Common things being common, bad primary tumor. Why are you surprised? And our clinicians push to get that molecular assay. There are situations in which we push to get molecular assays, but I wouldn't recommend it on all cases. I would recommend it only on cases where it makes a huge difference to the management of the patient and where you are unsure as a pathologist. I think common things being common, in many cases, you can compare the primary tumor with the MET, and you can perform some simple immunohistochemistry. So for example, I had another case, very similar case a few days ago. Again, pancreatic primary. The morphology looked a little different, but this time I used immunohistochemistry because I had access to blocks on both cases. And I did a P16, I did a SMAD4, I did a P53, and I forget one more stain. And the two tumors look immunohistochemically virtually identical, right? So if the immunohistochemistry sort of matches, particularly if you have the original primary and you can get them to match, I would say it's totally unnecessary to do molecular. But if there are open questions and it makes a huge difference to the patient's care, I think it's worth doing it. The question you should always ask is, what if it was your mother or your father or your cousin or your brother? You know, would you do it? And that's the litmus test I use. And I mean, it's a judgment call, and everyone is going to have a slightly different call. Yes, if you want to be absolutely perfect, you want to, you know, nail down a diagnosis and you want to be 100%, I think the only 100% we have now is sequencing, particularly now that we can sequence large number of genes relatively cheaply. I would say go for it if you can.
So thank you, sir. I have some more questions from the audiences. The question number one is, how do you basically differentiate, and what is your approach to differentiate pancreatic intraepithelial neoplasms versus ductal cancerization from a PDCA?
Wow. I have a very sophisticated audience. That's an awesome question. I haven't been asked that question from either my residents or my fellows for a long time. So this is a problem, right? So it's not a diagnostic problem until you hit it at the margin, right? So you know, you have a transected margin and you see something really atypical, and you're asking yourself, is it cancerization or Panin? One of the rules of thumb I've used is abrupt change. So generally when you see Panin, the whole duct looks uniformly atypical. When you have atypical glands and abruptly there is lower atypia, that to me is cancerization. Cancerization is also when it looks ugly and looks like the primary tumor. And one of the issues that comes up is, you know, are you sure that it's even a duct, or is it just a cancer duct, right? And there I go back to my favorite stain. You'll probably have guessed it by now. It's elastic. Around each pancreatic duct, there's a cuff of elastic fibers. So if you want to know whether it's a duct or not, try an elastic stain. And if all else fails, you know, P53 and SMAT4 can help as well, depending. And it's really nice because you can get a P53. Generally, you know, you have the background tumor, you have the Panin lesion, and either the null phenotype or the strongly positive phenotype. And you, of course, you got to be lucky because P53 mutations are found in only 50% of cases. But if you use that combination of SMAT4 and P53, you can solve that dilemma fairly often. But it's like dysplasia in the GI tract. What I like to see to make a call of dysplasia is that abrupt transformation, where I can point to a cell and say, this cell is non-dysplastic, and the cell right adjacent to that is dysplastic. In Panin versus cancerization, in cancerization, I can tell this cell is Panin and this cell is cancer. When I have that abrupt transformation, I find that very useful to make that distinction. Again,
So,
am I right 100% of the time? Probably not, but there's only so much you can do with an H&E stain,
yeah,
right?
we agree. Thank you, sir. Next question is, there is another interesting question. It was raised that, does the nature of the desmoplastic stromal reaction can help you to differentiate between a chronic pancreatitis and an invasive adenocarcinoma?
Oh, wonderful questions. Oh my God. Can I give the person who asked the question a hug? Such a great question. Let's virtual hug. You know, yes, it can help. But here's my question back to you. I promise you, what you call desmoplastic stroma, your next door neighbor will not call desmoplastic stroma. So essentially, both with chronic pancreatitis, you see fibrosis. With desmoplastic stroma, you see fibrosis. If you look at desmoplastic stroma, and I've spent some time looking at it, it looks slightly bluish and it is more inflamed, while chronic pancreatitis stroma is pinker and less inflamed. But these terms of slightly more inflamed, and are you going to make a cancer based on slightly more inflamed and slightly bluish? You know, you can't really count on it. We all know it when we see it, but in a challenging situation, that's not the only thing you can ever count on. I think there are several other features that are, you know, I would use before that, right?
Exactly.
So location, cytoplasmic quality, nuclear features. And if you're that desperate that you're going to use desmoplasia, you've really reached a very challenging situation. Yes, it helps, but I wouldn't put it up there in terms of features that help.
Exactly. We also agree to that. There was another interesting comments from one of our professors that she had a DOTA scan positive tumor, which was suggestive of neuroendocrine tumor. But on subsequent workup, it came out to be a type 1 autoimmune pancreatitis. She wanted to know why this tumor was DOTA scan positive. So you have any experience on that?
I have, that's a fascinating question. I have not experienced this before. I've certainly seen a large number of cases that have been overcalled as pancreatic cancer, and have turned out to be typically type 1 autoimmune pancreatitis. We used to see a lot of that in the early days, and I think it's becoming less and less common now. Um, in terms of the DOTA scan being positive, I mean, so the one thing you often, in fact, what is fascinating is I have a number of papers on the topic, and one of the papers that we wrote was about residual neuroendocrine cells in type 1 autoimmune pancreatitis. And it turns out, and my memory of that paper is somewhat hazy, and I hope none of the authors are in the audience to correct me, but I think we saw some endocrine cell hyperplasia in type 1 autoimmune pancreatitis. And when you look down at these cases of type 1 autoimmune pancreatitis, you tend to see a lot of hyperplasia and pseudo hyperplasia of the, whether it's hyperplasia or pseudo hyperplasia is somewhat hard to sift out. But we certainly see some let's just say that we see very prominent endocrine cell proliferation. And I just wonder if the scan picked up that endocrine cell proliferation. But that is unusual. I have not heard of that scenario before.
Yeah. Thank you, sir. And the last question I want to ask, what I found to be quite mind-boggling question. Someone asked, what is your experience regarding the histogenesis of Acinar cell carcinoma? Is it synonymous with Acinar cell carcinoma of the salivary gland? It is really difficult question, but if you have any word of wisdom.
Words of wisdom. Look to your wild side. That's the word of wisdom I have there on the screen there. Is there any, so I assume the question is trying to get to whether there's an overlap between acinar cell carcinoma and acinar cell carcinoma of the pancreas.
Salivary gland,
They sound, of the salivary gland and of the pancreas. They sound rather similar, and so they probably should have some association. But my understanding is there is no association between the two. But I'm going to sort of, and they're genetically different, right? So acinar cell carcinomas have BRAF abnormalities and BRAF fusions. As far as I know, and I don't keep track of the acinar salivary gland literature, you don't find BRAF fusion. So genetically, they are different looking. Histologically, they're different as well, right? Particularly with acinar cell carcinomas, you see prominent zymogen granules, which you don't see in acinic cell carcinomas. But just as an anecdotal, since we're finishing up here, anecdotally, one of the things that has always struck me is, you look at type 1 autoimmune pancreatitis in the pancreas, and you look at IgG4 related cystadenoma. Take a look at them side by side. Histologically, they're indistinguishable. It's amazing the overlap between those two entities. In fact, if you ever, and you'll be really lucky if you bump into one of these cases, if you ever meet a patient with painless obstructive jaundice, an elderly man with painless obstructive jaundice and bilateral enlargement of the submandibular salivary glands, I can almost guarantee you, regardless of anything else, that patient has type 1 autoimmune pancreatitis. Isn't that cool? And I've actually met a guy like this, and me and my surgeon made a diagnosis together even before we did any testing. We could still do that today. You can make a diagnosis based on clinical findings.
Thank you, sir. We really enjoyed throughout the session. And now it is over to Professor Chitra Sarkar, our chairperson, to have her concluding remarks. Over to you, ma'am, please.
Thanks, Vikram, for that very, very interesting slide seminar. It was really a journey from with HNE, and the younger lots generally just don't disregard HNE and want immunohistochemistry and molecular all the time. But the observations on HND, which we were taught in our old days, is something which you highlighted very well. And it was very interesting to see how each detail in the HND made a difference. Of course, immunohistochemistry and molecular are always there as aids and supportive, but as you rightly pointed out, sometimes can be confusing. But on the whole, thank you so much for enlightening us with this variety of cases. And it was actually fun the way you discussed it and with your words of wisdom, which I think all of us are agreeing. And that becomes a very important point when we tell people, when we preach, even when we are not asked to preach, but we do preach. And I do hope we'll have more sessions like this with you. And I thank you once again. And I thank my organizing team, the moderators, and all the audience. I hope you did enjoy. And sorry if all questions could not be addressed. But anyway, it was a very enjoyable experience. Thank you so much once again. And hope to get back to you soon with some more interesting.
That was wonderful. Thank you, Chitra, and thank you for those kind words. And I enjoyed myself. I felt like I was back home again, just for a moment. Thank you, everyone, and I thank the organizers for putting this together. It's no mean task. It's tough to put these things together. So thanks, everyone. Bye.
Venkat, is it something, because Venkat leads the whole team. So
Venki, you want to say something?
Oh yes, I would definitely love to say something.
A lot to say.
Thanks, Vikram, because it was really nostalgic for me. We were residents back together in the 90s when you and Anita were 6 months senior to me, and she wasn't yet your wife. The two of you showed me the ropes, and you were oozing wisdom back then also. You continue to ooze wisdom now. Of course, Gujral was our gang leader, and we had an awesome time because we used to go for lots of parties. And of course, in those days, we were at the receiving end of Friday conference slide seminars. Now you're delivering slide seminars for the whole world. And everybody is very happy to be at receiving ends nowadays. But may I say that the way you presented your webinar, it felt as if I was sitting in a reporting session with you, as I was reporting slides with you. And I think that's something which a lot of us would appreciate and cherish. Such a pleasure to meet you again, and an honor to have an alumnus deliver this webinar from Harvard. I would again want to express my gratitude to Dr. Chitra Sarkar, because starting this slide seminar is one of the nicest things she has done for the department. She has done a lot of very nice things. Most important of which is that she has made it possible for us to teach our postgraduates and undergraduates with digital pathology, just the way you were presenting, Vikram. And despite COVID, our teaching is still going on, just in different ways. A lot of our senior professors of our department, you will remember Dr. Manoj Singh, Dr. Amit Dinda, Dr. Rumare, Dr. Sandeep Mathur, Dr. Vaishali Suri. Everybody has been actually extremely encouraging of these webinars and to digital pathology adoption. It's sad that Dr. Karak is not with us anymore. He used to bring life to the parties we used to have with Dr. Manoj and Dr. Siddharth, who were the three musketeers of our time, who partied with us, although we were residents and they were consultants. Dr. MC Sharma, of course, has been right alongside in this webinar. He was our senior resident back then, very much a gang member. It has been fantastic to have our GIPAT team of Prasanjit, Rajini, and Madhu, and their efforts in disseminating the previous seminar also by Dr. Nayak to the GI pathology community were extremely successful. Dr. Anchal, Aruna, Kavneet, Madhu, and Ruchi, you're the team of young pathology members who make our webinar possible. And your youthful energy is very infectious, though that's a dangerous word to use in COVID nowadays, but it communicates a very happy and positive feeling to all of us. Thanks for all the senior faculty members, present, past, and retired. And the present faculty members, they're contributing a lot of the cases that we are putting up on the social media. And our team of young residents whose activity is so much needed for all of these. Thank you, one and all. Do watch out for the next month's webinar. With this word of thanks, let's bring this webinar to a close. Thank you all.